health professionals end up doing a lot of telling. And I don't know about you, but I'm not the kind of person that likes to be told what to do, generally. And most people don't like to be told what to do. And so when we're working with people around their health, telling them what to do is not effective. It's not working, especially not with chronic conditions that are lasting, for 20, 30, 40 years. People are living with, diabetes, HIV, hypertension for many, many years. And so these are some of the stats that have been shown in the research. People aren't taking their meds as prescribed. People aren't following lifestyle recommendations. Most people are not empowered or involved during a visit. They don't even speak during most clinical visits. So we're trying to change that paradigm so that patients become the center of the visit and they become more empowered through the use of health coaching.
Okay, that makes sense to me. So I think maybe everybody should be doing health coaching.
I mean, really, everyone should. If you're the kind of you want to make a change in your life, you should be offered a health coach. If you have a chronic condition, whether or not you're ready to make a change, but you're just willing to have a conversation, you should be offered a health coach. And when I say health coach, it could be anyone on the team, and we'll talk a little bit more about that later. But and everyone should be trained on the clinical team to be a health coach, not because they're going to be doing the coaching, but because we want everyone across the clinic to speak the same language. You don't want the clinician telling the patient what to do because they're rushed, and then you send them to the coach, and the coach is like super interactive and engaging and asking open-ended questions. It's just, you want the same experience throughout the whole visit. And so really everyone who wants a coach should have one.
Okay, well, you're starting to get at this a little bit about who can be a health coach, and so I just drew up some examples here, but I'm wondering if you could lead us through maybe what the role of a health coach is, who fills that role in practice, and maybe just give us one or two examples of what a model might look like in a practice.
That's great, yeah. So we've trained coaches that are patients. We've trained community health workers. We've trained all of these, different professionals that you see here on the slide. And really anyone can be a health coach. We've trained students, pre-med students, med students, nursing students, pharmacy students, pharmacists. I mean, anyone can be a coach. It's really about who you are as a person, like whether or not you enjoy coaching, whether or not you can use the skills, whether you have good people skills. And then most places don't do coaching in a very wraparound visit kind of way because they don't have the staffing for it, they don't have the room for it, and they don't have the time for it. And so when I'm thinking about models, the ideal model is thinking about ratios. So your clinician to non-clinician ratio needs to be higher than a one-to-one. So if you have one medical assistant working with one clinician and you try to train that medical assistant as a coach and you expect them to do like pretty intense coaching, you're going to fail because they won't have the time. So when you expand that the clinician to non-clinician ratio by either like bringing on more MAs, bringing in patients, bringing in students, then you have more of the capacity to do that coaching. And then you also need the room. So if you have a one-room or a two-room model, it's difficult to keep a patient in a room and coach them. So ideally, the patient has a pre-visit with the coach, patient has the visit with the coach in the room, the clinician leaves, the coach stays behind with the patient, and then to close the loop, and then in between, there's either coaching visits or telephone calls with the coach, or texting or some other kind of electronic communication.
Thank you. Yeah, I think that helps lay it out, and we'll actually come back to this about how to make this sustainable, how to make these models sustainable when people do have limited bandwidth for adding new staff. So we were going to try another interactive writing on the slide sort of thing.
Please work.
And I'm not sure if folks can see the little text tool at the top. If you can't see the arrow, I'm not sure that you're going to be able to see the text tool option to type in. but maybe some folks can chat in instead where they're feeling the extent to which their practice uses each of these following techniques as you currently understand them. So if you're ensuring understanding with your patient, do you strongly disagree, not sure, or agree, or, oh, it should be strongly agree. I don't, strongly disagree. Okay. And then knowing your numbers, making sure patients know their numbers, using shared decision-making, behavior change, medication adherence.
Can they write on this poll? Because if they can't, has anyone told you that they can or they can't yet?
A few people are saying that it's grayed out. So I think I have to give privileges.
Could they chat and just tell us if your practice is doing any of those things right now?
And I just assigned all attendee all privileges. Does that open up the graying at all? Great.
It works?
Okay, so there's this little P icon for text, and if you click on that, and then click anywhere on the table here, then you can write an X for your answer. I'm changing this to agree. Great, so we have someone who agrees that they're using medication adherence.
Yeah, that's awesome.
Strongly agrees, or beyond strongly agrees that they're understanding. That's great. Making sure patients know their numbers, medication adherence, great. Excellent. Okay.
Ooh.
So we've got behavior change. Very nice. We've got some experts on the call here, Mira.
Love it. Love.
All right, good. I'm glad that worked. Thank you for bearing with me as I am playing with this new technology. Okay. So let's start out with ensuring understanding. One of our learning objectives was to understand how to close the loop to ensure understanding for self-monitoring purposes. And so first of all, I'm wondering if you could help us just understand what does it mean to close the loop, and then maybe give us an example of how to actually do this.
So, yeah, I think most people in the healthcare setting, again, because of all the reasons we talked about earlier about feeling rushed, they try to close the loop. They just do it in a way that's not very interactive. And so they'll say, does that make sense? Or do you have any more questions? Or so you feel okay about taking your meds now? All of these really closed-ended questions. And most patients say yes to those things for a variety of reasons, whether they're trying to leave or they're trying to not, make you feel bad because you've just explained it, so of course they understand. So really closing a loop is about getting the other person to say what they're going to do. It's not so much about telling you what you just said. So I've heard some people try to close the loop by saying, can you just repeat what I said? Or say back what I said. But it's really like if you're asking someone about aspirin use, right? And you've prescribed them an aspirin, a daily aspirin, to improve their heart health. And they say, okay, that sounds great. Yeah, I'm willing to do it. And then you would say, okay, so just to make sure I was clear, starting tomorrow, tell me how you're going to take aspirin. Tell me when you're going to take it. Tell me how you're going to incorporate it into your daily life. And so really, there's two things happening. I want to make sure I was clear as the communicator because I'm the coach. I'm the person delivering the message, and I should do it in a way that makes sense and works for that other person. And then I want to make sure that the next day, when they're at home and they're not sitting in front of me, that they've incorporated this new thing into their daily life. So I'm doing both by asking that kind of question. So just to repeat that, I'll say, just to make sure I was clear, can you tell me tomorrow how you'll be taking your aspirin?
Okay.
And there's other ways to say it, right? Like just to make sure we're on the same page. you know, I want to make sure that we're gonna be doing this together, or something that just like, it's really about me as a communicator and helping you figure out how you're going to put this into your life.
Sure, and I think another thing that we think is important is making sure patients understand why they're taking aspirin, why you're asking, not just that you prescribe them this aspirin regimen, but why.
Yeah.
And I think I really appreciate that you give an example of what it doesn't mean and what it does mean. And I just want to alert people that in each of these slides, I've included links to videos that help demonstrate what it does look like and what it doesn't look like. So afterwards, when we post these slides, you can access those. I think those are really helpful.
The videos are great. We had health coaches and peer health coaches act as coaches and actors for 4 different types of coaching skills, and yet, like you said, they show the wrong way and they show the right way, and so it's a really good training tool and a reinforcement tool.
Great. So here's our first check-in. How are we doing so far? And we'll let you use the green check or the red X or type or chat in how we're doing. Are you still with us? I'm not going to ask it, does this make sense?
Don't say it. I'm concerned that maybe like people want something more in depth, because there are so many people who are doing this, and so if you have more in-depth questions, I'm not doing a deep enough dive, please feel free to chat in and ask those questions so I can do a deeper dive as needed.
Yes, please. And I see some green checks, and no red X's and no other chats. So we'll move forward and we can come back if we need to. Okay, so one of the measures we're looking at for this cardiac task is PQRS number 236, which is to increase the percentage of patients who had a diagnosis of hypertension and whose blood pressure was adequately controlled. So when we talk about adequately controlling blood pressure and we tell a patient you need to control your blood pressure, first of all, what does that mean? And secondly, how can health coaching play a role in accomplishing this?
So, you know, every clinic or program has clinical guidelines where there's a target goal, and many times patients don't know what those target goals are. They don't know if they have diabetes, what should their blood pressure be? If they have high blood pressure, what should their blood pressure be? And many times patients don't know their own blood pressure, right? And that's why is that happening? Because when someone's taking your blood pressure, this is what generally happens at most visits. Someone takes your blood pressure, they cuff you, you're sitting, they put the, the temperature thing in your mouth, they put the ox pulse on, they take your blood pressure, they're like, okay, good. And they take the cuff off and you go get weighed, something else happens. And so people are not taking the time when they're doing vitals, which is an easy way, an easy time to take a minute or two to tell people what their blood pressure is and to tell them what their goal is. And the reason that people should be doing this, like in the healthcare setting, health professionals should do this, is because there was a study that showed that patients who knew what their A1C level was and their goal was, as compared to patients who didn't know, were more likely to achieve that goal. And so when we talk about know your numbers, there are 4 questions that we want patients to know the answers to. That's, what does this number measure? So what is blood pressure? What is LDL measuring? The second question is, what is your number? So we want people to know their blood pressure. We want people to know their LDL. We want people to know their A1C. We want them to know their numbers. The third question is, what is the goal, right? It's really hard to get somewhere when you don't know where you're going. It's like getting into a car and driving without a destination in mind. So what's the destination? What's the goal? What are you shooting for? And that's based on clinical guidelines and clinician set preferences. So like, even though the guideline might say your blood pressure should be 140/90 for this particular patient, it might be a different number, but the patient should know that number. And ideally, as a side note, that number should be available to the clinical team in the electronic health record. And many times that's not available somewhere in the electronic health record. So it's really difficult to coach when you don't know what the goal is. And then the last question is, how do you get to goal? How do you get to that goal? What are the changes anyone can make, not you, but how do we know what the good strategies are for you to lower your blood pressure or lower your cholesterol? What can you do about it? The last question is, how do you get to goal?
How do you get to goal?
Yeah. How do you get there? And usually the answer is, healthy eating, not dieting. So no one likes to diet. So healthy eating, physical activity, moving around, not exercise. Nobody likes to exercise either. So physical activity, moving, right, being active, and taking meds. Those are the three big, broad categories. There's other things, right? Working on stress, reducing smoking, all types of things you could work on.
Okay. So I tried to chat in those, or I added those texts and those questions to our slide here. And this is another check-in. So again, how are we doing? Oh, we've got somebody clapping. That's so nice.
I see a smiley face.
Smiley face, green arrows. Okay. So I think we're on the right track. But again, if you think of something, please just chat it in. If there's another question and you need us to come back to it, chat that in. Okay. So another one of our objectives was to learn how Ask, Tell, Ask can lead to shared decision-making for improved heart health. So what is Ask, Tell, Ask? I mean, it sounds pretty straightforward, but maybe you could give us an example using cholesterol.
Okay. You want to role play this?
I think we'll role play medication reconciliation.
Okay. So Ask, Tell, Ask is, compared to what's typically done, which is tell, is really about engaging patients. And so thinking about how in any situation you can talk to a patient using more questions. So and lots of different questions. And I know that people asked about MI, and the questions, the health coaching questions and the health coaching question skills, like asking those questions, is based in motivational interviewing. So health coaching and motivational interviewing are aligned. It's just that health coaching also includes all of these other, really clinical kinds of skill areas like med-rec, and using MI to do those things. So know your numbers, using MI to help people know their numbers. So Ask, Tell, Ask is really about asking questions to gauge understanding, to gauge buy-in, to gauge motivation, and then only telling things that people want to know, right? There's no point in telling people something they don't want to know, because what we know about that is it leads to wasted visits. More than half of patients leave a visit without understanding what happened. And when you think about that, it's pretty crazy. That means, like, in the healthcare setting, half of the time is being wasted. People are leaving without knowing what was done, what was said, and then they're just like either coming back repeatedly, you have those high flyers, and like frequent visits, or they're like going to the emergency room or going to urgent care, right? So Ask, Tell, Ask is about making sure patients know the things you want them to know, they need to know for their own health, getting their motivation. So around cholesterol, for instance, we do a lot of tests on people and we don't even tell them what it means, but talking to someone about their cholesterol, like, what do you know about cholesterol? And then they would say, well, nothing. And then you say, okay, well, let's talk a little bit about what cholesterol means. There's good cholesterol, there's bad cholesterol. What do you know about bad cholesterol? And asking those open-ended questions, or what are you willing to do to change, or what have you tried in the past, those motivational interview questions, to get the patient to participate more. So stop now. There's a lot of talking. I don't talk this much when I health coach.
It's tricky on a virtual session, right?
Yeah.
Again, we've got a link here in the title to a video of an example of this. Again, what it does not look like and then what it does look like. So what it does not look like is, do you understand, right? Or
yeah, you need to work on your cholesterol. You have bad cholesterol, you have good cholesterol. We're going to prescribe you some meds. You're going to take the meds. When you go home, you're going to take one a day. And, you know, you're going to cut down on the animal fat that you're eating. You're going to try to get in more exercise. And, you know, you just need to be a little bit healthier to help your heart out and bring your cholesterol down. That's not what it sounds like.
And all I heard from that was you need to be healthier to bring your cholesterol down. So another check-in here, and we're looking for how we're doing. How is your understanding of the Ask Tell Ask? Oh, we've got someone who wants us to speed up a little bit, go faster. Okay, we can do that. We can do that. All right, and I see just green checks, so here we go. Another one of our learning objectives was to help you understand how to create action plans to support behavior change and improve cardiac health under the ABCS. So I thought I had attached an action plan template for an example, but I will do that again. And if it does not work with the technology, we will make sure that we send that to you and post it on the website, and you can download it. And it's just an example of what an action plan might look like. So maybe, Amira, could you walk us through the steps of creating an action plan for someone, for example, who's trying to quit smoking?
Right. So some of the mistakes I've seen when people make action plans is they're making them with people who are not ready to make action plans. So first, making sure that the person you're working with is ready. They're at that stage of change where they're ready to do something. And working on an action plan with a patient is about helping them either start a behavior or change a behavior. And all of that change is generated from the patient. So the other mistake I've seen people make is doing a lot of suggestions, like, why don't you do this, or why can't you try this, or how about you do that? And it's that kind of putting ideas into people's minds doesn't work, right? You want the inception of that idea to be the patient. You want them to generate what they're willing to do, how much they're willing to do, what do they want to work on. So around smoking, you know, if someone's like, yeah, I smoke, you ask them that basic question that we have to ask once a year, the guideline, which is, how often do you smoke, right? And I stay away from the do you smoke question because that's a yes or no. So how often do you smoke? And if someone doesn't smoke, they say I don't smoke. Someone says I smoke, you say okay. How long have you been smoking for? How much do you smoke? And what are your thoughts about quitting? And if someone says, you know what, I've been thinking about quitting for quite some time and I'm ready to do something. You say, oh, okay, that's wonderful. So, you know, what are you thinking about changing? What is it about smoking that you want to change? And they might just say, you know, right now I feel like I could cut down 1 cigarette. And that might not be a big deal to you because you're like, they smoke 2 packs a day. So like 1 cigarette is like, okay, just the tip of the iceberg. But if they're willing to start there, we say yes. So we say, that's great. Let's start with 1 a day. And when do you think you can start that? And then we do a confidence check. So on a scale of 0 to 10, 0 being not confident, 10 being really confident, how confident are you that you can cut down 1 cigarette a day starting tomorrow? And they say, oh, I'm like a 7. I'm an 8. I'm a 9. I'm a 10. We say, great. So anything lower than a 7, like 6, a 5, a 4, you have to go back and revisit. Well, why are you a 5 and not a 10? Maybe they're just not ready yet, or maybe it was too much. Maybe they said they're going to cut down half a pack, but really that's too much for them. So you want to help them set these realistic goals, even if it's really a small goal, so that they can achieve it and feel good about themselves. And probably, I would say the most important part of an action plan is the follow-up. So if you make a plan with someone and you never follow up on it, there's really no point in making the plan, right? It's kind of like making a date with someone and then not showing up for the date. There's no point in making the date, right? So if you're going to make plans, you have to have the resources, the time, the follow-through to check up on that patient and see how it's going, and then modify the plan as needed. And that form that we're trying to upload is just an example form. A lot of people do this electronically now. But something that the patient can take home with them that says their plan on it is helpful.
Thank you, Mira. And I did upload the action plan here, although it's only showing the first page. So I will make sure that that is included in the materials when we upload them to the website. Another check-in point for folks, how are we doing? I see one person raised their hand to speak. I don't know, Karma, if you'd like to share something from your practice. Let's see, I'm going to unmute you. Hi, Karma.
Where are you?
Maybe not. Maybe we'll come back to her. I also chatted her, so maybe she would like to share later. Okay. And I see green checks. All right, moving right along. Clapping again. I love it. Okay, medication reconciliation. I know we've got some experts on the call, a lot of people who said, yes, we agree that we are practicing medication reconciliation with our patients. And I want to learn a little bit more about what this looks like in practice and thought we could do maybe a role-playing activity to sort of practice this. We've got some questions here. And we're looking for volunteers. So I will play the patient, and we need someone to ask you questions. But maybe, Amira, while we're waiting for volunteers, somebody just raised their hand. You could give us a little background about this process.
So as you can see, this process takes a long time. There's lots of questions, and that's the reason most places don't do MedRec, is because it's time intensive, and it requires someone who's been trained and feels comfortable doing the meds. When we train our health coaches, we train them on all the basic medications, because if a patient should know about their meds, why shouldn't a health coach who's not a clinician know about the meds? But it's nerve-wracking for like medical assistants or students or peer coaches to learn medications. But once they do, and you have like a good resource to use in terms of knowing what the meds are for, and you have the time to do it, it's so helpful to have a patient bring in all their meds, and you sit down with them and you take the hour that it takes to go through their 10 different medications and figure out what are they taking, what are they not taking, how's it going? And you know, the typical way this is done, the wrong way that it's done, is you're prescribed Vinazepam 10 milligrams for your blood pressure. You know, have you been able to take it? And patients are like, yes, I've been taking it. And what we really, really know is that 1/3 of patients don't take any of their meds. 1/3 of the patients take some of their meds, and 1/3 take most of their meds correctly. So about 2/3 of the population are not taking their medication. So when someone's sitting in front of you and they say, yeah, I'm taking my meds, they're probably not. And it's not because they're intentionally lying to you. It's because they need the time and the space to sit down and have a discussion about what's really going on with those medications. And there's a good video on YouTube for MedRec.
Also linked here in the slides. And I don't see any hands volunteering.
Better voluntold them.
Voluntold, we might just pick somebody.
Mm-hmm.
Brave volunteers or a voluntold.
Oh, pick someone, Rebecca. You can do it. That's what I do in my trainings all the time.
Anna Fisher, would you be willing to be our brave volunteer to practice this process? I'm going to unmute you.
You can do it.
Hi, Anna. Are you with us? We've got some shy folks on the call. Okay, it's intimidating.
Carrie Beck, who's that?
Okay.
She said I can volunteer if you need someone.
All right, Carrie. I don't see your audio here. You're not connected to the audio, so we can't unmute you. All right, Anna says her microphone isn't working. we could just go down the line.
Go ahead, do it.
Darlene, would you be willing to volunteer?
All you have to do is read the questions, Darlene.
Charlene, would you be willing to volunteer?
No, she said, is that an X as a no?
X as a no. Interesting. But we can wait until we get a volunteer.
Very shy.
Very shy.
Is there someone who's a coach now who could just jump in? Because coaches aren't generally shy. So if there's a coach that's on the call now, they should be able to just jump in and do it. All you have to do is follow the script.
Karma again? Let's try it. Hi, Karma. Are you with us?
All right, should we?
Maybe you and I should just do it.
Wow, yeah. Okay, let's do it. Okay.
Okay.
So, Rebecca, is it okay if we talk about your meds a little bit?
Yeah, sure. I felt pretty weak yesterday, and I took my blood pressure and my sister's machine, and it said I was 86/50. So I just laid down for a bit, and then, I thought I was taking my medication for blood pressure just like the doctor told me to.
Okay. Okay. So let's talk about that. So your blood pressure was 86/50, you said?
Yeah, I think so.
Okay. Well, we just took your blood pressure, and look, can you tell me what it was?
No, I don't remember.
It's okay. That's okay. When we just took it, when we were doing your vitals, it was 125/75, actually.
Oh, is that good?
Well, what do you think?
I think so.
What's your goal that you've set with the clinician?
I don't know. Maybe you could walk me through that again.
Oh, it's fine. So the goal that I have in your file says 140/90.
Okay. So I'm not there.
Well, what was your blood pressure this morning?
120/65.
So what's your blood pressure compared to the goal, which is 140/90? Is it higher or lower?
Lower.
Yeah, it's lower, which is good.
Oh, okay.
Which is good. Now, it's something like 80/50 is quite low. So let's talk about your meds and see what's going on.
Okay.
Okay. So did you bring your med bottles with you?
I did. It's right here.
You're awesome. That's fantastic. Okay. Let's start with this one. So what's the name of this med?
Anazapril.
That was perfect. Spot on the first time. That's awesome. Okay. What is this med for? What are you taking it for?
It's for my blood pressure.
Absolutely. Now, does this medication make your blood pressure higher or lower?
I think it makes it lower.
That's correct. Perfect. Okay. So how many milligrams are in each pill?
It says here 10 milligrams.
Yeah, exactly. And how many are you taking? How many milligrams are you taking?
10. Well, I take one in the morning and then one at night, so 20 milligrams.
Okay. And what do the directions on the bottle say?
It just says take one pill in the morning.
Okay. All right. So you've been taking one in the morning and one at night.
Yeah.
Okay. And the directions are telling you that you're supposed to be taking one in the morning.
Yeah. Well, I just thought, more is better, and I had really high blood pressure before, and so I thought I'd better just take two.
That makes sense. That makes sense. And that might explain if you've been taking your blood pressure and it's been a little bit lower or a lot lower. So what I'm going to do is I'm going to let the clinician know that you've been taking twice the amount because maybe there's some adjustment that needs to be made, and and we need her input. We need her input because I'm not a clinician.
Okay.
So I just want to bring it to her attention. So let's see if that impacts your care plan and helps, you know, her make a decision for your blood pressure. How do you feel about that? Can I do that?
Yeah, I feel okay. I just don't want the doctor to be upset.
Nah. No, this happens all the time.
Okay.
She's going to be happy that you told me and that now we know.
Okay.
Yeah.
I feel good about that.
Awesome. Okay. And just for the future, how do you get your refills and how do you know how many you have left?
Well, I think it says here how many refills I have left, and I usually just pick it up at the when I'm here in the clinic.
Oh, at the pharmacy here?
At the pharmacy, yeah.
Okay. And how many pills does it go down to before you call? You know, you pick it up?
Usually when it's empty, I'll call and then I'll come in and pick up a new one.
Okay. How's that been working for you?
Well, last time I went a couple days where I wasn't able to come into the pharmacy, and so not good, I guess.
Yeah, and since you've been taking twice as much, I'm imagining you're needing refills sooner.
Yeah.
Okay. What do you think would be more helpful in the future when we figure out the dosage in terms of not running out of your meds and having meds when you need them? And how could you do your refills a little differently?
Maybe, I guess, if I have maybe 7, one for the rest each day for the rest of the week, I could call and come in then.
Okay, that sounds like a good idea. All right, so I'm going to just let the clinician know about your benazepril, and let's talk about your next med.
Okay.
Cool. All right. Thanks, Rebecca.
Thank you. Okay. So that's how it goes.
And you can see it takes a long time, right? You see that, like, and to do that with every med, with every patient, it takes a long time, which is why a lot of places don't do it and don't do it thoroughly. So we went over a lot of things. We went over how you're not taking it the way it was prescribed, how you do your refills, what another trigger could be instead of like waiting until the bottle's empty, you know, oh, like I have 7 left, now it's time to trigger a refill. A lot of things that we don't talk about with patients. So a lot of patients just walk into the clinic for their refills when they don't even need to do that because they can go to the pharmacy or they call, lots of calls into the clinic about refills. So MedRec also helps alleviate that kind of demand on the clinic.
Yeah. Okay, and I want to ask to check in, but I see a lot of checks already and a couple of fast forwards, so we'll just move right ahead and talk about implementation. And when we talk about implementation, sometimes we get a lot of these problem statements. Well, it's not going to work because of this, or we really can't do it because we don't have this. And so I wonder if you could just lead us through some ideas about how to make this a reality in practice, and what are some of the problems that practices face or think that they're facing or will face, and maybe some examples that you've seen to overcome these.
Well, if there are people on this call who are implementing and have overcome any of these things, it'd be so helpful if they were like to raise their hand or chat in the chat box, because that lived experience and sharing with your peers about how it's done is so useful, and people really need to hear from other clinics how it's being done. How did you do it? How did you do it? And so I can give you how I've coached clinics through doing it. When people say we don't have the time or we don't have the personnel, it's about figuring out what personnel can you move around, or can you bring in student volunteers? Are you working with the local university or paraprofessional program? Can you train peers? Have you looked at the most underutilized resource, which is patients? Like, we just are not using them the way we could be using them in a clinical setting. And to really expand your capacity in not just for health coaching, but for all the other problems that we have in our medical system, expanding capacity through alternative appointment types where you're doing a lot more shared medical appointments or group visits. That frees up time for the MA and the clinician to be doing other things. So if they see 10 patients in an hour or 2-hour block or 20 patients, that frees up a lot of their time throughout the rest of the day to be able to offer coaching visits or do coaching calls. Those are some of the solutions, but I'm so curious to know what people are doing already. Wondering if anyone wants to share.
We've got somebody, let's see, Charlene said, we have RN care coordinators who have a schedule that we can block time to meet with patients after the visit with the provider and also schedule patients to meet with the RN.
Perfect. Yeah, that protected time. You can't, like, a lot of people just want to incorporate health coaching into the regular role. Like, yeah, just do health coaching. You can't just add it on. It's not an add-on feature. It's really, you need something that's protected. You need that time just for coaching.
And I am looking at the time, and I'm aware, and I do want to respect people's time. There was a question about whether there will be time for questions, and we haven't had any questions submitted yet. But if you do have them, please submit them, and we will answer them in real time. But we'll move through just maybe one more example about concerns and talk through next steps and how you make this happen in your practice. So we've got two. We've got concern, lack of funding, and then lack of space. Which one do you want to cover, Amira?
I can do both fairly quickly. So I know a lot of people have heard about coaching flip visits, but in case you haven't, it's where a visit where a non-clinician starts a visit. Or a nurse starts a visit. There's nursing flip visits too. That's what I'm basing this off of. But the coach starts the visit and conducts most of the visit so that the clinician can just pop in and do the clinician level things. But the patient is told ahead of time, you're going to get 5 to 10 minutes with the clinician, but this is really a coaching visit. Then you can bill for that visit, right? So it's figuring out how can you bill for the things that you're doing creatively, then also utilizing peer coaches, which are basically free. And then in terms of space, that's a huge issue, and a lot of creativity goes into that. One big step is co-location, so moving clinicians out of their offices and moving nurses out of the nursing station and the MAs out of their MA station, and getting people to sit together on teams. So the clinician, the nurse, and the MA are sitting together if they're on the same team. That opens up room. But there are people that do really creative things around using alternative space, like using a closet, converting a space in your clinic that you never thought of as a coaching space into a coaching space.
Great, yeah, it shows some ingenuity when you know that it's important to have this work done. People will figure out a way. We did have 2 questions. So one question is, should staff doing health coaching get any kind of special training or certification?
There's not a national accreditation body around coaching yet. There's lots of places that train health coaches. So the Center for Excellence, where I was working before at UCSF, when I was there, we developed a curriculum, and that's where I did most of my training out of. And through that center, we trained thousands of people. But they, coaches need extra training because of the techniques and the skills and the people interaction. You don't get that in nursing school or MA school or medical school. They're not there yet. Some medical schools are using it, some nursing programs are using it, but it's not embedded into the curriculum in most of those schools yet, so there needs to be additional training. There's just no formal accreditation programs that are nationally recognized yet.
Okay, thank you. And then there was another question about, are there any special considerations for aged or disabled populations?
So when I think of special populations or seniors, geriatric, I think about home visits. And I know in Oregon that's happening, right? There's home visits being done by health coach specialists. They have a different name, but resilience specialists. So like meeting people where they are, going to their community, going to their homes and doing coaching in the home, which is so powerful. Anyone that's done a home visit knows, you get to see so much of what's going on in the home that helps you really understand what the patient needs. And then, a lot of like language concordance. So you need a coach that speaks the same language and ideally the same culture, so that you can give suggestions that are doable, that are feasible.
Okay, thank you. And then we'll still keep fielding questions, and we can email you afterwards if we run over time a little bit. But Amir, I want to thank you for your time today, and I want to thank everyone else for their time being on this call. And I thought we might just end by providing some next steps for folks. So if a practice were to consider adopting health coaching as a method to help their patients with complex needs, what should they consider doing next?
I mean, the first thing they don't do. First thing you should not do is train people. And I know people love to jump to the training, like, I want to train my people. And what I tell them is, have you done all the groundwork? So have you figured out your model of coaching? Have you figured out who's going to get the coaching, where they're going to get coaching? Have you altered the workflows? So like altering workflows, figuring out the patient, the target population, figuring out who is going to do the coaching, where it's going to be done, what part of the visit it's going to be done in, how often are you going to coach, how are you going to measure success, right? Figure out that stuff first and then give people the training that they need so that after they're trained, they can jump right into the coaching and not have that big delay that tends to happen between training and implementation. And figure out how you're going to sustain and spread. You don't want the program to die after the funding runs out if you have special funding, or if this one person that got trained leaves, which happens a lot. So figure out how you're going to sustain it and spread it. Figure that stuff out and then do the training.
Okay, so are there any resources people can look at for figuring that sort of thing out, the sustainability piece? I put in at the end of the slide, there's some links to resources about figuring out which model might work best for their practice, but do you have any other resources people should look at?
I would look at places where they're doing health coaching. So, in Great Plains, Colorado, and High Plains, Colorado, there's a clinic called the High Plains Community Center. They're doing health coaching there. There's the Iora Health model, where most of their clinic time is spent on coaching. Union Health Center in New York does a lot of coaching, and they have their own training curriculum as well and professional development. So find the places that have been doing it and see how they do it and what they've done. And a lot of those places not only give protected time, but they have workforce development programs. So you move up this ladder of health coaching, and that comes with more pay and more experience, and it gives people an incentive to keep it going.
Okay, thank you. That's very helpful, and I want to thank everybody else on the call too for being engaged and being patient with some of our technical issues. And thank you again, Amir, so much for your expertise and helping to share with us. So just wanted to let everybody know that the slides will be posted on the website with the recording shortly. And please do give us feedback on how we did today. I put a link to our SurveyMonkey in the chat box. It should also pop up afterwards, but just in case. And our next webinar will be March 15th at 9:30 a.m. Pacific Time, 10:30 a.m. General Mountain Time, and we'll be discussing panel management. So we hope to see you there. But otherwise, thank you so much, everyone, and have a great rest of your Tuesday.
Hey, Rebecca.
Yes, I'm still on.
Hi.
Hi. Thank you so much for, I'm just trying to turn off the recording.
Yeah.